Welcome everyone. I'm going to let everyone get settled in virtually here before we begin. It's great to see a couple of familiar names and nice to have you. We'll see if we have anyone. I'd like to disable the waiting room too, Kate, if we can, if one of us can. See if I can. Yeah, I think we're okay now. Late folks joining late can join us without being held up in the waiting room. So looks like Amanda's still getting connected to audio, and we'll let everybody else get settled in. And I want to just welcome you all. Good morning or good afternoon, depending on where this broadcast finds you today. This is our ESAS presentation today, which is Essential Substance Abuse Skills webinar series, our longstanding webinar series. Again, I'm really happy to have you all here. My name is Steve Steiny. I'm one of the program managers here at our National American Indian Alaska Native ATTC. I'm speaking to you live from the University of Iowa here on campus in Iowa City. And our speaker and lecturer today is Dr. Avis Garcia. She is coming to us from Salt Lake City, Utah. So we're happy to have her with us today. And she's got a lot of great information that we'll be going over. I will assume that many of you are practicing clinicians or working in the behavioral health field. So some of this information may be review for you. If you're new to the field or maybe getting back into the behavioral health direct services field, this will also be a great refresher for you. Our focus today will be on clinical evaluation and screening. And this is part of, as I said, a much larger overall series. And these are all connected to core functions of working in the substance abuse or mental health co-occurring disorders field. So there's a lot of tie-in with our ESAS and those working in the field. So happy to have you here today. Sit back and enjoy, and we'll hopefully have a little time at the end to take some questions. And I know Kate Trams is on now. She'll be assisting initially with any technical difficulties. And then I'll be with you for the remainder of the broadcast as Dr. Garcia shares some information with you. So I'll try and keep an eye on the chat box, and we'll circle back to any questions if we have a little time at the end. So again, happy to have you all here. And I've got a few intro slides, then I'm going to turn the floor over to Avis Garcia. So thank you for being here today. I want to just remind everyone, as most of you may know, this event is brought to you by the National American Indian Alaska Native Addiction Technology Transfer Center. As I said, we're located at the University of Iowa. We are part of a national ATTC network made up of 10 regional centers, a national Hispanic Latino center, as well as a coordinating office at the University of Missouri in Kansas City. Let's see if I can get my slides to go here. There we go. This Zoom screen keeps getting in my way. So it's the Zoom world we live in, ladies and gentlemen. I want to remind all of you too that this project is supported and funded by SAMHSA. The content is developed by the presenters, and the opinions expressed do not necessarily reflect the views or policies of SAMHSA, HHS, or the American Indian Alaska Native ATTC. Following today's event, we will follow up with you via email, and we will include PDF copies of the slides today. We'll also be recording today's event, and that is available if you would like to access this or share this broadcast later with a colleague who maybe wasn't able to attend. We do have a YouTube archive through our Native Center for Behavioral Health where all of our broadcasts, or almost all of our broadcasts, are available for viewing on demand. We'll also offer 1.5 CEUs, and in that email that you receive, you can request to have CEUs that are NADAC approved for this webinar today. And we will have a short survey. I can't forget about our survey. The survey is important to us. We'll post the link for that survey in the chat box, and the GIPRA survey, it's about a 5-minute survey, will also be attached to the email that we send out in our follow-up. You don't have to complete the survey, but we would really appreciate your feedback. You can skip any questions you would like, and you have my word that none of the information you share can be connected to you directly, and it's completely private and confidential. We do value your feedback, and it really helps support continued events like this at no charge to you or the other participants. So if you have a few minutes to fill that survey out, we would greatly appreciate it. I want to, before we move into today's speaker, I do want to say that we are gathered here virtually today, but we would like to take the time to acknowledge the land and pay respect to the indigenous nations whose homelands were forcibly taken and inhabited. Please take a moment to read this land acknowledgement, which was created by 3 members of our team, Ella and Keely Driscoll, and our co-director, Sean Baer. Thank you. Without further ado, I would like to introduce today's speaker, Avis Garcia. Avis is an enrolled member of the Northern Arapaho tribe and is affiliated with the Eastern Shoshone tribes of the Wind River Reservation in Wyoming. Avis is a LPC and an addictions therapist. She holds a doctorate in counselor education and supervision, and with a specialty in substance use disorder treatment and work with Native Americans. I consider Avis a colleague and a friend, and she's got a lot of experience, decades of working in the field. She's worked with all ages and different groups, couples, family, but her specialty really is SUDs and trauma. And her therapeutic approach is to privilege indigenous knowledge and draw on the strengths of individuals and families to promote intergenerational healing through research and clinical work. Really happy to have her here today to share some important information with you about clinical evaluation and screening. You are muted, and we're going to keep you muted for the duration of the lecture today. If you have some questions at the end, you feel free to unmute yourself and you can ask them directly to Dr. Garcia. I'll watch the chat box as well, and we can circle back to any questions that you may have. So again, I want to turn it over now to my colleague and friend, Dr. Avis Garcia. So Avis, you have the floor. Great to see you. Thank you.
Thank you for the nice introduction. Let me share my screen. Okay, thank you all for coming here today to attend this presentation on screening. Oops, get this to back up. As he shared with you, I have several years of experience in the substance abuse field and the mental health field. I currently am employed by the Crow tribe as the director of their recovery center. And I have been here in Salt Lake City for, gosh, going on 3 weeks, going on 4 weeks now. So a little bit about myself and my personal life is my daughter has been in the hospital with COVID, and I'm happy to say she is doing well and she's recovering, but I continue to stay here just to provide her support. And I'm real grateful to the Crow tribe for allowing me to continue to stay here and be with my daughter. And so that I've been real appreciative of their understanding of my personal situation while I continue to do my work. And we'll get on to the presentation today. This presentation will focus on the screening process of alcohol and drug abuse patients. It is the first step in the process to determine whether or not the patient recognizes that they have a need to change their behavior. The next step is to interview the patient to determine whether he or she describes behaviors that are predictive of alcohol or drug abuse and asks specific questions to further describe the nature of the problem. Accordingly, this presentation will progress through the material in the following order. First, I have a quote here that says, "A patient's substance use is not the problem, but rather a symptom of underlying issues that may be the cause of why they started using in the first place." So give that a moment to sink in and think about that. It's often become one of their coping mechanisms to whatever issue it is they're facing in life. And once it becomes beyond the coping, control can be lost, where it can lead to serious problems in all areas of one's life. The clinical evaluation and screening. Today, we will go over the introduction and overview. We will talk about the stages of change, facts about change, cover the FRAMES model. It is a brief intervention for alcohol problems that is part of the motivational interviewing process. Differences between screening and assessment. Screening for substance use. I will take questions and comments. And then we will look at the DSM-5 screening and assessment and treatment options and modalities, all based on the time that we have. On to the next slide. Prochaska and Di Clemente are well known for developing the stage of change model in the 80s, which was an initial effort to capture the change process of cigarette smokers. And it has been used since to look at change in other addictive disorders, including alcoholism and even with medical issues. I've heard of it being used with diabetes, for example. Prochaska and Di Clemente, the stages of change, readiness to change model, covers the pre-contemplation, the contemplation, determination and preparation, action, maintenance. It also looks at relapse and recycle as a normal part of the change process, and also termination or graduation. Although it is not a perfect circle, it can also be viewed as a spiral of change. Looking at the stages of change, we'll begin with pre-contemplation. This is a person who is probably not even considering change and does not see their behavior as a problem. So at this point, readiness to change would be at 0%. They see no reason because to them there is no problem. And in the old days, the clinician might have called this stage denial, or either they might see themselves as not that bad. Maybe they really did just make one mistake. Contemplation is the second stage. This is where the person is a bit ambivalent about change, and they might acknowledge that there might be a problem. The next slide. The next stage is determination and preparation, where we may have someone who is more committed to change, and they made a decision to change. They see that they do have a problem and they would like to make some positive changes. The next step is action. They are involved in the change and they may be actively implementing a plan. Oftentimes I've had patients come in for their assessment and they may be happy to say they've already, had so many days of sobriety or clean time, and, they're very proud of themselves for the work that they've done. So that's always a good sign. The next stages are the maintenance with the relapse cycle and recycling. This is the behavior change, a high confrontation with a high confrontation level with new behavior and undesired behavior. So there may be some slips in the relapse process. And this is with any addiction. It doesn't have to just be drug and alcohol. This could be process addictions too. They're, something may have triggered them to use or engage in whatever behavior it is they're working to extinguish or reduce. And then we have the termination or graduation, where the change is very stable and the problem behavior appears to be resolved. There are people who are really committed to changing. And from my personal viewpoint, I see change as when they first come into my office, as we've got a 50-50 chance of helping this person along with them, that we don't change them. They do a lot of the work themselves. We are just there to guide them through the process. Here is a model of the process of change by Prochaska and D. Clemente. As you see, we covered the pre-contemplation. There's the contemplation, the preparation, action, maintenance, and the relapse and recycle. So I often think of this as maybe somebody might be planning to maybe lose some weight. So they may be thinking about it and then realize they really want to do it, and then preparing, maybe planning a diet, maybe planning some exercise, whatever it is they think is going to be helpful to them, and engaging in the action. Once they get their routine down and are comfortable with it, they'll work on maintaining that. But then there's always these relapse issues that you need to prepare them for. That I also wanted to point out that this readiness to change is part of the ASAM criteria. And it is dimension 4. When I write up our assessment reports, we do have to address the ASAM in our reports as required by CARF. So we have to also state what their stage of change is and as evidenced by what. So, with the action change, I might say this person has, they have 60 days of sobriety, they're attending all their groups, they're going to AA meetings, they've got a sponsor, anything that substantiates the action that person is taking. So just to keep that in mind. Facts about change: it is a natural process. It is brief counsel, and brief counseling can speed up the change process. We are here to create a therapeutic alliance with the patient. It is important to have faith, hope, and efficacy as important elements in your work. It also helps the patient to have other supports. Counselors do matter. Empathy is not merely having had a similar experience. Sometimes it may be something we haven't experienced, but we need to be able to put ourselves in their place and imagine what that might be like for that patient. People engage in change talk and resistance talk. So you might want to just ask yourself in general, why do people change? Why would someone want to change? They usually become ready when the consequences that they're experiencing begins to outweigh the benefits of the related decision or behavior. So maybe going to the bar on Friday after work has led to them getting a DUI, possibly losing their job, their driver's license. Some people lose everything before they realize that they need to make some changes and are willing to be brave enough to seek some treatment and change their behavior. The next step is the interview skills. We will go over micro-counseling and motivational interviewing. This is to initiate discussions with the patients that facilitate the acknowledgement of possible substance use disorders. There is a continuum of substance use disorders. There are people who may engage occasionally, and then there is at the other end of the spectrum of the disease of addiction. So when we are assessing our patients, we want to look at where is this person at? Looking at a scale from maybe 0 to 10, with 10 being a full-blown addiction, they meet the criteria for dependence. Most patients are frequently reluctant to share for some common reasons. 1, they're embarrassed. 2, they do not want to be judged, and they don't want to be denied or forced into treatment, and they do not want to be reported or arrested. So a lot of times I worked in agencies that still do urinalysis as part of the assessment process, and so a lot of them are very concerned that we're going to report them to someone. And so disarming them and making them feel more at ease should be done on paper as well, so that they know, you're in agreement with, not reporting to law enforcement or whatever. I just reassure them that it's to help us get a baseline of where they are. So on the form, you might want to state, in order to optimize your substance abuse assessment today, we need to ask a few personal questions. Be assured of all the information that we obtain will remain confidential and will not be reported to anyone else, including our family members or law enforcement. So this is just to help us get them the right type of care that they need. Micro-counseling skills. This is from Alan Ivey, and he is a distinguished university professor at the University of Massachusetts and professor at the University of South Florida in Tampa. Micro-counseling is, I want to say, these are your very basic counseling skills that you might receive in your maybe introduction to counseling class. It's an analysis of counseling skills that looks carefully and in great detail at the elements of the counseling relationship. Regardless of the aims and methods of the counseling relationship, understanding its micro elements, so its pieces, helps the counselors improve their counseling effectiveness. Let me see. On to the next slide. Counseling skills are basic foundational skills that are involved in effective helping relationships. These are the foundational tools on which successive interventions with clients may depend, helps create necessary conditions for positive change to take place, may aid and establish rapport with clients, and constructs empathetic understanding, genuineness, and acceptance. This greatly facilitates the development of a safe therapeutic environment. Like I said, you want to create a therapeutic alliance with your client. Micro skills are a set of verbal and behavioral responses that facilitate the process of counseling and alliance formation, regardless of your theoretical orientation. These skills are presented in a hierarchy that is organized within a systematic framework. To begin with, we have attending behavior and attending behavior. So attending is the counselor's interest in the patient, demonstrated by eye contact, body posture, and accurate verbal following. And the attending behavior encourages the patient's disclosure and active listening. This is at the bottom of the framework. And these can include your eye contact, your body language, and your tone of voice. As I said, my daughter has been here in the hospital, and I've been spending most of my days there, often working in her room while I'm there. But I've seen the different people that come in, and I've also seen how they interact with people. And yesterday, she had these occupational therapists come in, and one of them was just really awesome. She was just really encouraging. She had this real uplifting attitude. She just, I mean, she made me even feel good when she came in the room with all of her behavior and everything. Even when she left, I still felt like she really made a good impression on my daughter, really making her feel like she wanted to make some changes for herself. So I might consider this to be maybe similar to a bedside manner of how you make the patients feel comfortable when they come to you, because it takes a lot of courage for them to get there. Your attending skills would be good communication. Again, it involves more than just verbal contact. Much communication takes place non-verbally. Clients rank nonverbal gestures and presentation and body language as the most important alliance building factors. Nonverbal attending communicates your warmth, interest, and understanding. This can also include eye contact, body position, and your tone of voice as well. Eye contact. Good eye contact conveys interest, confidence, and involvement in the client's story. Clients with difficulty of closeness, eye contact can be a vehicle of change. There should be natural breaks in eye contact, ebb and flow as you listen to the client's story. It's also essential to be sensitive to the differences in how eye contact is expressed in Native culture. And there are over 570 federally recognized tribes across the country, and we all have different languages, different values, different ways we go about living our daily life in the world, and there are different levels of acculturation, from those who have fully assimilated to being bicultural to those who are more traditional. And I have, throughout my years, worked a lot with Native Americans, and quite often I have seen a lot of clients, especially those that come in for substance abuse treatment, and the adult people I usually get when they're having more problems in their life versus the younger population that this may be their first time. I have had people that do not look at me at all. They may look down, they may look away, but they're listening to you, and they are they're talking to you. They're just not comfortable with making eye contact. And some people just have different beliefs about what that means for them in life in general. So it's good to pay attention to that if you're working with the Native population. Your body position, facing the client, being open, relaxed, and attentive. Don't cross your arms or legs. Don't sit behind a desk or any other barrier if possible. Lean in with your upper body toward the client. Let them decide the physical distance by offering to let them arrange the chairs to their comfort level. Sometimes I've got 2 chairs in the room, and I'm like, wherever they feel comfortable. And being mindful of your own personal space too. I've had some people just get right up in my space, so you have to be mindful of that. You should convey your interest and involvement. This will assist you in putting the client at ease. And like I said, remind yourself of your own professional boundaries as well. You might want to offer a glass of water. If you have a snack, sometimes just little things like that, at least in my culture, we always share something to drink and something to eat. Your vocal tone, pitch, pacing, and volume all have an effect on the client's response to the counselor. Our emotions are frequently conveyed by our tone of voice, so you need to prepare yourself to be mindful of your voice as well. Your voice can help create a soothing and anxiety regulating atmosphere for the client. Learn to use your voice as a therapeutic tool using some verbal underlining, which is increased vocal emphasis to certain words or phrases that helps convey a sense of empathetic understanding. Questioning. These are your primary skills that allow you to gather the important and specific information that you need about them. Questions allow us to make an accurate assessment of their issues and guide the focus to make effective use of the time. Sometimes I have to redirect them because us natives are storytellers. So in response to a lot of questions, there may be storytelling. So you may have to remind them we need to stick to the assessment. And, if we have time at the end, we can talk more about what they wanted to share. Used inappropriately can impede communication and block client disclosure. So if you're leading or confrontational, they can shut down on you or not give you any information at all, and do not drill the client with questions, especially when working with native clients. There are different types of questions. There are open and closed questions. Open questions cannot be answered in a few words. These questions offer encouragement and the patient will speak more freely. Closed questions focuses the dialogue and tends to focus on the professional and away from the patient. And this is farther up the skills hierarchy in the basic listening sequence. It includes questioning, paraphrasing, summarizing, and reflection of feelings. Open questions elicit fuller and more meaningful responses by encouraging the client to talk at greater length. Typically begins with what, how, could, would, or why, and are useful to help begin an interview, to elaborate the client's story, and help draw out specific details. With open questions, the client can choose the content and direction of the interview session. So be careful when using why questions. Whys can often cause the client to become defensive and feel put on the spot. Leading questions in nature often places too much power in the hands of the interviewer. The closed questions elicit a yes or no type of response. Too many closed questions can cause shutdown and become passive. They may just tend to sit back and wait for the next question to answer yes or no to. So it's always good to begin with open, more general questions and then move to the closed specific to obtain some specific details. Refrain from moving too quick into closed questions unless unable to obtain any information otherwise. Your patient observation skills. This is the nonverbal behavior and is 85% of communication. Verbal behavior keywords. Pay attention to the keywords, discrepancies in the patient's communication. There may be some mixed messages. There may be contradictions, conflicts, and incongruities. Oftentimes, when you're working with patients in the clinical justice system, if they're referred by courts, it's real helpful if they can give you documentation up front, because you're able to use that information to help gather information and get information in regards to substance abuse causing legal problems. The next part of the assessment and screening would be encouraging, paraphrasing, and summarizing. So here, reflecting feelings. Here's where you'll reflect the patient's feelings, either stated or implied as expressed by the counselor. And feelings of the patient can be both nonverbal and verbal. Reflecting meaning. Finding the deeply held thoughts and feelings underlying life experience. Paraphrase is to thoughts as reflection is to feelings, and break down complex behaviors into parts. And do not repeat the client's exact words. You might want to use an appropriate introduction phrase, such as it sounds like you're feeling upset, or you're feeling depressed, or you're feeling, sounds like you're feeling anxious, or it seems like you're very worried about, what's going to happen after the assessment here today, or what's going to happen in court. Pay attention to the tense. Present tense reflections can be more powerful, so paying attention to what's going on in the here and now. Reflect mixed emotions. They may be having some mixed emotions about whether or not they think they need to get some help or not. Check out the accuracy of their reflections and feelings with the client by asking them, am I right? Or it sounds like you're realizing that you're beginning to have some problems in your life because of your use. Or, are we on the same page? Would you agree that? So being able to ask those types of questions to reflect their meaning back. Having empathy. Understanding what the patient is experiencing and putting oneself in the patient's place. Functions of empathy builds a firmer relationship with the patient, enables the counselor to better understand the patient's behavior. Common problems with conveying empathy can be language and cultural differences between the patient and the counselor. So don't lose sight of your role and purpose as the therapist in the situation. On to the motivational interviewing. This is by William Miller and Stephen Rolnick, who are well known for this motivational interviewing. They originally developed this to increase motivation of patients with issues related to alcohol problems to change their behavior. As part of that process, Miller found that approaching patients with a modified patient-centered approach increased the impact of the interview. What has evolved is a communication style and focus that increases the patient's motivation to work on their problems. So it is a person-centered approach. There is also evidence that Miller was strongly influenced by tribes in the Southwest when conceptualizing the motivational interview approach to actively engage, communicate, and empower people to make changes in their lifestyle choices. It has been culturally adapted and widely accepted and utilized in many Native treatment facilities and behavioral health providers across the US. So it is proven to be effective in work with Native Americans. If motivational interviewing is a way of being with people, then its underlying spirit lies in understanding and experiencing the human nature that gives rise to the way of being. How one thinks about and understands the interview process is vitally important in shaping the interview. So some examples would be, it sounds like your job is important to you. What would happen if you quit drinking for a while? If your life were to start getting a little better, what would you be doing differently now or in the future? Or if your life were to improve, if you stop drinking or using, what would that look like? Who would notice? Motivational interviewing is a patient-centered approach. This is also an approach highly recommended by CARF, which is an international accrediting agency worldwide. This increases patients' response to screening and assessment and adherence to treatment, improves treatment outcomes by enhancing the client's motivation to change. So they get to take the lead here. Rationale. Clinicians commonly think that they are already practicing motivational interviewing when they screen, assess, and treat. What makes motivational interviewing a unique counseling approach is how its skills are employed by the clinicians. Motivational interviewing requires attention to timing issues, specific strategies, application methods, and maximizing the effectiveness of these skills. So using specific language and strategies to empower patients to make informed, self-directed decisions about themselves and their lives. And most important, to elicit the notion that change is possible for everyone. From a screening context, motivational interviewing is non-judgmental and often allows the patient to reach their own conclusions about their substance use problems. Two phases of motivational interviewing: assist in screening, assessment, and patient change. The first is building motivation for reliable assessment and specific change. This includes the use of those open-ended questions, affirmations, reflections, and summarizing everything. And this also is strengthening the commitment to change, which builds on the patient's own motivation. So where they are and in the change process and the resolve to change. So this is where we're looking for change talk. You know, maybe they're starting to see that they have a problem and want to start doing things differently and how they're going to go about doing that. The basic principles of motivational interviewing are to express empathy, develop discrepancy, rolling with the resistance, now called dancing with the scored. Of course, not everyone is happy to come and get an assessment to begin with. So it's meeting them where they are, whether they're happy about it or not. Support the self-efficacy and the optimism. Again, letting them know that change is possible for everyone that wants to do it. Avoiding argumentation and direct confrontation. Miller and Rolnick changed the terminology from rolling with resistance to dancing with discord. In the third edition of their book, I appreciate how this further enforces the notion that it's not our patients that are resistant, in denial, or difficult, but rather how we as providers may be misreading their readiness to change, trying to push change into them rather than elicit the desire to change from within. Imparting information does not work effectively when the patient is not ready for it. In addition, I might think I know best how patients should go about making change. However, patients know more about change, how change will work in their lives. Resistance and discord in the provider-patient relationship provides us with an opportunity to revisit our intervention and change course instead of arguing with the patient to change behaviors. It's far more effective to elicit their internal desire to change. The more we elicit their desire, ability, reasons, and needs to change, the more likely that they are to make the change. Motivational interviewing is a fundamental approach that is collaboration with the client, evocation and suggestion, and autonomy, the self-rule. 4 principles are to express empathy, not sympathy, dance with discord, develop discrepancy, and support self-efficacy. Brief intervention for alcohol problems. 6 common elements of the brief intervention include the frames. This is an acronym for frames the feedback. F is for feedback of personal risk. R is responsibility of the patient. A is advice to change. M is a menu of ways to reduce drinking. E is an empathetic counseling style, and S is the self-efficacy of the patient. So we are there to guide them, support them, encourage them, be their cheerleader, but we are not there to fix them. Differences between screening and assessment. The first, as you can see here on this axis, is time and the comprehensiveness of assessment. So when we're screening, the amount of time that it's going to take is very minimal. This is where we can rule out whether or not we think this person needs to go into a deeper assessment of their use disorder or mental health problems. So making a diagnostic assessment, again, time increases. And then beyond that would be a personal evaluation and treatment planning. So the more they need help, the more time it's going to take. So there is a difference between, and when you're screening someone, it's just screening them for whether or not we think they need more in-depth, where we maybe bring out more deeper tools to use with that patient. Difference between screening goals and assessment goals. Screening is designed to reflect the likelihood of the presence of substance abuse. I have noticed over the years that a lot of medical doctors and nurses or people in general in the medical profession are beginning to ask patients questions that might be obvious from their medical assessment of patients regarding substance use. So they may do a quick screening of them and tell them, I think you should go get an evaluation, because I have had patients say, well, my doctor said I should come in and see if I need to get some counseling or some treatment or something. So that is the screening. Assessment is designed to provide a broader range of information on the degree, kind, causes for, and possible treatments of the abuse. So this is where we might be looking at, is this a DUI? They just need to, first time they've ever had a DUI. Maybe they need early intervention, which is the ASAM criteria of equivalent to a 0.58 to, I don't know, several states have different ways of providing that level of care. Maybe an 8-hour substance abuse class specific to DUI. And that may be it. Maybe they have had a little bit more problems and we're looking at outpatient treatment and so forth, requiring more time and more effort of both the therapist and the patient. You might want to think of assessment as a platform for making treatment recommendations, where screening is more likely to rule out the need for further treatment. More differences in screening goals and assessment goals. Screening instruments are typically brief, require yes or no answers, can be administered by non-experts, and are obvious in their intent. Assessment instruments generally are more time-consuming, can require more complex historically based information, benefit from use by experienced trained evaluators, and are not always obvious with the intent. Assessment is also usually comprehensive and often involves a cross-referencing of gathered collateral and historic information. Some of these people may be repeat treatment people you've seen in the past, which I see from time to time. Here are some examples of some screening tools for substance abuse to help identify possible substance use disorders. There is the behavioral observation, observing the patient. Collateral informants, eliciting information from friends, other providers, corrections, public records, spouse and relatives. Laboratory tests. Are laboratory tests consistent with patient collateral reports? This can include the UA. Like I said, sometimes medical professionals have sent people to us because maybe their blood work is showing some possible signs of body liver damage. And here are some self-report screening measures. There's the CAGE, adapted to include drug use. The RAP S4 is the quantity and frequency. How often are they drinking and how much? Are substances they're using and how often? The MAST and the MAST2, the TACE, the TWEAK, the SBIRT, which is quite popular with the medical profession, and the audit. So these are very brief screening tools to determine whether this person needs a more intense evaluation that we refer to as an assessment. Going into a little bit more depth on the CAGE Aid Questionnaire. This is by Ewing from 1984. A cut point of 1 detects about 90% of those with an alcohol-related disorder, with 48% false positives. This is using the CAGE. Have you ever felt you should cut down on your drinking or drug use? Have people annoyed you by criticizing your drinking or drug use? Have you ever felt guilty or bad about your drinking or drug use? Have you ever had a drink or used drugs first thing in the morning to steady your nerves or get rid of a hangover, also known as an eye opener? The CAGE screening technique has been adapted to include drugs. The patient is asked if he or she has ever had to cut down on his or her use of drugs or been annoyed by the criticism of their drug use. The RAP S4 and the RAP S4 QF is sensitivity better than cage? With good specificity, addition of quantity and frequency questions outperforms the cage for alcohol abuse at a cut point of 1 across a wide range of groups. During the last year, have you had feelings of guilt or remorse after drinking? Has a friend or family member ever told you things you said or did while you were drinking that you can't remember? So some amnesia. Have you failed to do what was normally expected from you because of drinking? This is your performance. That's the wrap. Do you sometimes take a drink in the morning when you first get up? Starter. And the QF of consumption of alcohol that includes the quantity and frequency. So how much and how often is this happening? For example, in the last year, have you had 5 or more drinks on at least one occasion? Quantity during the last year, do you drink as often as once a month? Looking at the frequency. The Michigan Alcohol Screening Tool, known as the MAST. Here's the questions. Do you feel you are a normal drinker? So they can rate themselves in response on a scale from maybe 1 to 5. Does your wife or husband or parent or other relative ever worry or complain about your drinking? Do you ever feel guilty about your drinking? Do your friends or relatives think you are a normal drinker? Are you able to stop drinking when you want to? Have you ever attended a meeting for Alcoholics Anonymous? Has drinking ever created problems between you and your wife, husband, parent, or near relative? The MAST 2 is a little more in depth. Have you ever gotten into trouble at work because of drinking? Have you ever neglected your obligations, your family, or your work for 2 or more days in a row because of your drinking? Have you ever gone to anyone for help about your drinking? Have you ever been in a hospital because of drinking? Have you ever been arrested or for drunk driving while intoxicated or driving under the influence? Driving under the influence of substance, doesn't just have to be alcohol. Have you ever been arrested even for a few hours because of other drunken behavior? Alcohol screening instruments for pregnant women. There is the T-ACE with the T representing tolerance. How many drinks does it take to make you feel high? Have people annoyed you, criticizing your drinking? Have you ever felt you ought to cut down on your drinking? Eye opener, have you ever had a drink first thing in the morning to steady your nerves to get rid of a hangover? Another screening instrument for women is the tweak. Again, looking at the tolerance, how many drinks can you hold? Worried, do you have friends or relatives worried or complaining about your drinking in the last year? Eye opener, do you sometimes take a drink in the morning when you get up? Has a friend or family member ever told you things that you did not remember, known as amnesia? Cut down, do you feel the need to cut down on your drinking? And here is the SBIRT. This is the screening, brief intervention, and referral to treatment. This is a real popular tool. Again, a lot of medical professionals are being trained to use this. The SBIRT is an evidence-based approach to identifying patients who use alcohol and other drugs at risky levels with the goal of reducing and preventing related health consequences, disease, accidents, and injuries. Risky substance use is a health issue and often goes undetected. For men, how many times in the past have you had 5 or more drinks in a day? None, 1 or more. Women, how many times in the past year have you had 4 or more drinks in a day? None, or 1 or more. As for drugs, this includes recreational drugs that are methamphetamines, also known as speed and crystal, cannabis, known as marijuana, pot. Inhalants includes paint thinner, aerosol, glue, tranquilizers such as Valium, barbiturates, I always have a hard time saying that one, cocaine, ecstasy, hallucinogens, including LSD, or mushrooms, or narcotics, which is heroin. How many times in the past year have you used a recreational drug or a prescription medication for non-medical reasons? None or one or more. Then we have the audit, the alcohol use disorders identification test. This should be administered to adult patients who screen positive on the pre-screening for alcohol use. Side 1 contains the screening questions and side 2 contains instructions on scoring and interpreting the audit. Substance use related disorders in the DSM-5 includes 10 substance related disorders. That is the alcohol related disorders, the caffeine related disorders, cannabis related, hallucinogen, inhalant, opioid, sedative, hypnotic, and anxiolytic related disorders, stimulant related disorders, tobacco related disorders, and other substance related disorders. Almost all substance-related disorders in the DSM-5 include substance use disorders, substance intoxication, and substance withdrawal. Almost all specify that the substance use disorder be rated as mild, moderate, or severe. Exceptions include caffeine use disorders. They don't have any severity ratings. Hallucinogen use disorders have no intoxication or withdrawal. The inhalant use disorder has no intoxication, and the tobacco use disorder also has no intoxication. Alcohol use disorders include alcohol use disorder that is mild, moderate, and severe, alcohol intoxication, alcohol withdrawal, and unspecified alcohol-related disorder. And being more specific on how to determine the level of alcohol use disorder, someone with a mild use disorder might have 2 or 3 symptoms present. The moderate alcohol use disorder might have 4 to 5 symptoms that are present, and the severe would have 6 or more present. Unspecified alcohol-related disorder is another diagnosis that can be used when determining a substance use disorder. Under the DSM-5, the diagnosis applies to the presentation in which symptoms characteristic of an alcohol-related disorder that cause a clinically significant distress or impairment of social, occupational, or other important areas of functioning predominate but do not meet the full criteria for any specific alcohol use disorder or any of the disorders in the substance-related and addictive diagnostic classes. So there are 11 symptoms. The alcohol use disorder is a sign of a problematic pattern of alcohol use leading to a clinically significant impairment or distress that is manifested by at least 2 of the 11 listed symptoms occurring within a 12-month period. Symptoms of an alcohol use disorder can include taking alcohol in larger amounts over a longer period than intended. When I go out to a bar or a party, having resolved to drink no more than 3 beers or spend no more than 2 hours by the end of the evening, I've had 10 beers and been there for 4 hours or more. The next one is a persistent or unsuccessful efforts to cut down or control use. Time and again, I've tried to control my drinking, but I've never been able to do it. The third one is spending a great deal of time and activities necessary to obtain alcohol, use alcohol, or recover from its effects. Alcohol takes up a lot of time in life. What with getting the money to buy it, spending time at the bars, consuming it, talking to friends, and getting over whatever hangover I might have developed from my drinking. Can also look at it as a loss of control, which would be an inability to predict when the loss of control will occur. More symptoms is a craving or strong desire or urge to use alcohol. This is a new symptom. When I haven't been drinking for a day or two, I'll begin to experience a strong craving for alcohol, which stays with me until I get rid of the craving. Recurrent alcohol use resulting in a failure to fulfill major role obligations at work, school, or home. It will sometimes happen that my drinking makes it impossible for me to go to work, so they miss work, or they're not taking care of their family, makes them feel terrible, but they'll still do it. So there may be a preoccupation with drinking or drug use, which can indicate the presence of psychological and physical dependence. And if the term is repeated, 2 or more counts as repeated, this may often come in the form of legal consequences. So they may have an extensive legal record or beginning to have more than one legal problem in their history related to substance use. They may have lost jobs, lost their family, burned a lot of bridges because they've been able to control their use. More symptoms are continued use of alcohol, despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of the alcohol. Even though I have a tendency to become angry and sometimes violent when I've been drinking, I continue to drink and suffer the consequences of my anger. Important social occupation and recreational activities are given up or reduced because of alcohol use. I used to like to dance and visit friends and family, but since I've started to drink, I've given up almost everything that doesn't involve drinking. So the key word to watch out for here is recurrent. Recurrent alcohol use in situations in which it is physically hazardous, such as having had 3 DUIs, having been in accidents because of my drinking, which was pretty seriously injured. Every time I'm able to drive, I've been drinking. So that can be really dangerous for other people that are just innocent people. And number 9, alcohol use is continued despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been exacerbated by the alcohol. Even though I almost always get very depressed after I've been drinking for some time, I continue to drink. I don't know why. It doesn't make sense. So this could indicate the presence of a medical issue or condition or psychological disorder, coupled with the continued use making the condition worse. So these situations, it's hard to tell that they have the depression or the anxiety before, or did this happen as a result. So over time, you'll be able to tell when they've been off the substance long enough. Looking at the tolerance and need for markedly increased amounts of alcohol or drugs to achieve the intoxication or desired effect, or a markedly diminished effect with continued use of the same amount of alcohol. So they're now requiring more alcohol or more substance to achieve the initial effect. The withdrawal, the characteristic withdrawal for alcohol or a closely related substance such as benzodiazepines is taken to relieve or avoid the withdrawal symptoms. It's very important to rely on your collateral medical lab reports to support these criteria, particularly when the patient appears to be underreporting or is denying the use of a substance altogether. So I have 2 new, very young therapists working for me, and we do get patients, even myself, after all these years of being a therapist and doing evaluations myself, that can still, I always say I'm not a lie detector. They will come in and intentionally not give you enough information to get a more accurate assessment of their use disorder. So when they brought this up in one of our meetings recently, I told them, you know, I would suggest you just write that up, as that's exactly what you saw, and letting them know that we will probably have to have them go through another assessment with another person, because of what we were able to see was not enough to give us an accurate reporting based on other information that we have. So oftentimes they either come clean then, or sometimes they're angry, they're not always happy. So just know that it happens. And then there's the withdrawal characteristic, withdrawal syndrome for alcohol. Physical withdrawal from drugs like alcohol and benzodiazepines can be life-threatening. Medical support or management must take priority. So sometimes we are called to the emergency rooms or the hospital to come and do an assessment. And some of these patients, you know, they do need to be there to manage those symptoms, because there is better care there for them, for the medical conditions that they may be experiencing. The alcohol use specifier changes. The DSM-4 used to be a physiologic dependence. It would be with physiologic dependence or without physiologic dependence, to the newer version of the DSM-5 with a severity specifier of mild, moderate, or severe. So we may have an alcohol use disorder that is mild, moderate, or severe. And then you also want to note their status of early remission, sustained remission, or controlled environment. And do we have any questions or comments about the stages of change, the facts about change, the interview skills of the micro-counseling skills and motivational interviewing, the frames, screening, the DSM-5, treatment options and modalities? Any questions, comments?
Davis, I think we were quite shocked as a group to hear that patients don't always tell the truth. So thank you for all these years. I've just been taking everything they say at face value. Yeah, Jason's on board with me there. So we're enlightened, and we appreciate that information.
Yes.
Just wanted to say thank you. It was a great presentation. It's good review. Coming to you from Washington State, Fort Gamble Slalom Reservation. Yeah, a lot of it was really good review. So thank you.
Thank you. Okay, no more questions. I have a few more slides to continue here. And looking at the treatment options, this is looking at detoxification, pharmacological maintenance, outpatient, extended and intensive, partial hospitalization, inpatient residential treatment, and continuing care or community-based support groups. What I'm seeing a lot more of lately are the sober living housing situations, and from my experience, those appear to be working well for those areas that are able to provide that. One of the challenges I have is the area where I moved to work is I don't have a ready job opportunity for them to go to on the Crow Reservation. They have better opportunities in Billings, but that is like an hour away. But then I also learned that there is a transportation system that is available, and I have suggested that to them. On the Wind River Reservation, where I come from, one of the things I've seen happen that has been really positive is those that do go into the sober living situation that is now offered through the Arapaho tribe, is the tribe has worked out a program with the casino that the tribe owns and operates. We actually have 3 casinos. Well, let's take that back to 2 because they shut one down because of COVID. But we have 2 casinos, and they do have transportation system so that a lot of these clients that are in that sober living can get transportation to go to work at the casino. So it's like almost a guarantee if they really want to work their program that they can get a job too. So that's something new that's taken place. Evidence-based treatments for alcohol abuse include motivational enhancement therapy, cognitive behavioral coping skills therapy, 12-step facilitation, community reinforcement, behavioral couples therapy, pharmacological treatments such as anxiolytics and opioid replacement therapy. The medication-assisted treatment is available in most areas. I know the Crow tribe has the opioid response program, and it also focuses on prevention as well. Here, again, we're looking at the continuum of care, looking at on one end of the continuum of looking at there's the higher acuity of the emergency room and hospital, looking at inpatient and hospital in a detox, going to a residential treatment center. Some places offer a wilderness program. I haven't seen much of those where I'm at, other than we do incorporate some outdoor experiential type activities using our cultural counselor that is in the program I work at now. He does take the clients out to go pick medicines, maybe go to sacred sites, and taking them to the sweat lodge. Recovery residents. Again, this is the sober living housing that I really think is just a really positive treatment program, because it appears that those that are struggling just want to work. They want to do good. So this is a real good opportunity for people to make that positive change. And then there is the low intensity recovery residents. Again, this is like the sober living. We have the partial hospitalization, the intensive outpatient programs. Again, every state has their different required hours of treatment that they have to attend, required number of classes to attend. So I'm learning there's been a huge difference in where I come from, the Wind River Reservation to the Crow Reservation in Montana. So there's been some big differences for me. So I've learned a lot in making a change. And then we have the self-help groups. There are a lot of people who do really well with the self-help groups. Those that I've seen in treatment that engage in self-help groups seem to do a lot better from my perspective, but not all of them are interested in it. And always incorporating your culture, whatever that may be, wherever you come from where I come from, the sweat lodge has been really popular. And I have seen some people that have gone back just to participating in those ceremonies has been, I want to say, like maybe the only thing they've utilized, but they're sober and they're really liking making that connection to their culture. And so I really support that in the work that I do with Natives. Evidence-based psychosocial treatments for alcohol abuse. Again, motivational interviewing. It heightens motivation to stop abusive drinking by providing the patient objective feedback on its likely impact on health and the quality of life. Cognitive behavioral coping skills therapy identifies situations that represent substantial risk for continued drinking and using, helps develop skills to cope with those situations. So it's a lot of coping skills, teaching them coping skills for anger, for stress, for anxiety, and self-efficacy to believe that changes in drinking can be made successfully. So building up their self-esteem and their self-confidence. There is the 12-step facilitation therapy, prepares the patient to benefit from involvement in AA. Community reinforcement approach provides the patient access to community resources and personal reinforcers contingent on maintenance of sobriety and other prescribed behavioral changes. Vocational rehab, I think, is a really good example of this. You know, as long as they're staying sober, they can get some support to get some job training. And behavioral couples therapy addresses abusive drinking and alcoholic spouse and the associated troubled couple interactions that often accompany abusive spousal drinking. Evidence-based pharmacological treatments for alcohol abuse can be anxiolytic, for example, Abuse Bar, leading to short-term reductions in alcohol consumption, and alcohol-dependent individuals suffering from depression, medication-assisted treatment, naltrexone or Suboxone, and I can't pronounce this other word, this Camprol. These words are tongue twisters for me, to reduce cravings following detoxification, which also increases the likelihood of continued abstinence and recovery. And that is the last of the slides that I have. We have any thoughts, ideas, any questions about what was presented here today? I thought I would just let you all know that tip 35 from SAMHSA, the treatment and improvement protocols, covers the motivational interviewing information, and it is free if you go to the SAMHSA website and download it. Nothing, nobody? Well, if that's it, I'd like to thank all of you for taking time out of your busy schedules today to be here to listen and learn. And I hope this has been real helpful for you in refreshing your skills or learning to help our people that are hurting and need healing. And I'm glad you guys are there. It shows you care about the people that you are helping by being here today.
Thank you very much, Avis. We appreciate you. This is a great review of a lot of information. I appreciate Jason Gomez sharing some of his news from his direct service world. And I see David Garcia also asked, be interested in hearing more about traditional or ceremonial ways of addressing SUDs. And I think that might be a great topic suggestion, David, for future webinars as well, either a behavioral health webinar or just a separate event. So I appreciate that, and I'm logging that as making a note to myself to talk with our staff here about that. I want to just again thank everyone. We had a small group today, but it was really great to have everyone here with us. I did post a link to our short survey. We'll reach out to all of you via email, and you can fill that short survey out at that point. And if you'd like CEUs today, we will offer 1.5 CEUs that are NADAC approved. You can use towards your licensure or accreditation, or your credentialing certification. So really happy to have everyone here. We'll broadcast next month. I'm not sure, Avis, what's our topic for next month? I meant to jot that down and it's escaping me. It may be a continuation of discussions related to assessment, referral, and treatment planning, and some other components. So please feel free to join us again. Watch your email for our listserv. If you're on our list, you'll get an announcement inviting you to join us. So until then, please stay safe, stay connected, and stay healthy. And we'll see you again soon. Thank you, everybody.